Good practice run. Okay, so I'd like to go ahead and once again, we'll start our introduction. My apologies. I want to welcome everyone to the California Northstate University College of Pharmacy webinar series, CNU-Capital Leadership Forum, titled The Future of Pharmacy, Exploring the Impact of COVID-19 on Pharmacy Practice and its Implications on the Roles of Pharmacists within Healthcare. We are so glad to have such a distinguished group of panelists with us today. I want to also welcome those of you joining us from home. We've had an incredible response, which I really think speaks to the caliber of the individuals we have here today. The vast majority of attendees are students from the California Northstate University College of Pharmacy, University of Pacific, Touro University, and other colleges. I want to welcome our students and congratulate all of you for taking an active participation in the future of your chosen profession. We are going to start this evening with some brief introductions of each of the panelists, followed by a panel discussion. Then from 7 o'clock to 7:30, we will entertain questions from the audience. You can ask questions on the California Northstate University Facebook page, where Mr. Jonathan Ballard will forward the questions to me to ask our panelists. I would also like to take this time to introduce myself. I am Peter M. Tenerelli, and I'm an assistant professor of clinical and administrative sciences here at CNU-COP. I am director of the Center for the Advancement of Pharmacy Practice and president-elect of the Sacramento Valley Pharmacists Association. Today, I will be your host and moderator. I'd also like to thank our Dean, Dr. Xiaodong Feng, for his strong support of the CNU-Capital Leadership Forum series. In addition to being Dean of the CNU College of Pharmacy, Dr. Feng is also the CNU University President of Admissions and Student Affairs. He is a professor of medical education with over 20 years of experience in clinical practice and biomedical research in cancer, wound healing, and cardiovascular disease. He has 2 U.S. patents for anti-angiogenesis and cancer treatment strategies. We thank Dr. Feng for his leadership and vision as Dean of the California Northstate University College of Pharmacy. Thank you, Dean Feng. So we're going to go ahead and start with our introductions. Our first panelist is Ms. Susan Bonilla. Ms. Bonilla is CEO for the California Pharmacists Association, the largest state association representing the pharmacy profession in all practice settings. Prior to her current role, she served for 6 years representing Contra Costa County in the California State Assembly, and for 8 years as the local elected official on City Council and as a member of the Contra Costa Board of Supervisors. While in the Assembly, she chaired the Business and Professions Committee when SB 493, expanding the scope of pharmacy practice for pharmacists, was heard and passed. She also served on the Health Committee for 6 years and advocated for increased access to health care during the implementation of the Affordable Care Act here in California. She has a master's degree in educational leadership. Welcome, Ms. Bonilla. Our next panelist is Dr. Laurie DeMartini. Dr. DeMartini is CEO for the California Society of Health System Pharmacists. Prior to her current position, she held several senior level leadership positions with the California Department of Public Health, including Chief Pharmaceutical Consultant and Deputy Director of the Office of Quality Performance and Accreditation. She has held leadership roles within CMS Hospital Faculty, CMS Long-Term Care Expert Panel Member, American Society of Consultant Pharmacists Advisory Board Member on Medication Use in Long-Term Care Facilities, contributed to the Institute of Medicine's report on medication errors, and membership on the Public Health Accreditation Improvement Advisory Committee. She currently serves as an associate clinical professor at University of California, San Francisco School of Pharmacy and an associate clinical professor, Touro University School of Pharmacy. She is a fellow of the Healthcare Leaders Network with California Healthcare Foundation and is a member of the Health Impact Board of Directors. In 2019, she was inducted into the California Pharmacy Association Hall of Fame. Welcome, Dr. Martini. Our next panelist is Dr. Lisa Gunther Lum. Dr. Lum is the Medication Safety Officer at Adventist Health Medical Center in Glendale, California. Dr. Gunther Lum left Kaiser Permanente after 34 years of service, where she held various positions from Director of Pharmacy, Finance at their corporate pharmacy office in Downey, Drug Education Coordinator, and Inpatient Pharmacist Specialist at the Kaiser Permanente Medical Center in West Los Angeles. Dr. Gunther Lum is currently president of the California Society of Health System Pharmacists and has served in the past as CSHP Treasurer and on the CSHP Board of Directors. Dr. Gunther Lum is also the immediate past president of the CSHP Research and Education Foundation. Welcome, Dr. Lum. Our next panelist is Dr. Richard Dane. Dr. Dane is an associate professor of clinical pharmacy and residency program director at the USC School of Pharmacy. He is an advanced practice and board certified ambulatory care pharmacist with expertise in immunizations, tribal health, and community-based pharmacy practice. He is an advocate for the profession of pharmacy in the state and currently serves as the Speaker of the House and Chair of the COVID-19 Task Force for the California Pharmacists Association. Welcome, Dr. Dane. Our next and final panelist tonight is Mr. Mikey Hothe, who is District Director for California State Assembly Member Jim Cooper. He has held this position since 2014 and led efforts to bring resources back to his community, namely $4 million in funding for the Elk Grove Food Bank and $1 million in funding for Lodi Lake. Mr. Hothe is also on a number of community boards and commissions and is a tax oversight commissioner for the city of Lodi. Welcome, Mr. Hothe. So I'd like to show our panelists here and go ahead and begin our questions. And our first question is for Ms. Susan Bonilla. And I would like to start with the question, in March, you assumed leadership of CPhA, and one of your first challenges, and a very big one at that, I must say, for just starting out, was COVID-19. How has CPhA, under your leadership, approached the pandemic and reacted to both the needs of the patients and the pharmacy professional community?
Well, thank you, first of all, so much for this invitation. It's really a pleasure to be here with you and with the audience as well. And it's an honor to be able to discuss the future of pharmacy. So you're right, I was dropped right in at the deep end. And after 2 weeks on the job, we ended up going home and dealing with this pandemic. And I would have to say that it really was evolutionary. I think at first, none of us realized how long and how deep this crisis was going to be. And so we made some adjustments and then realized that, oh my goodness, we are going to have to do some really major resourcing, education, and I think above all, collaboration to deal with this situation. Coming together was very important. So one of the very first things we did when we thought about the needs of patients, it's about access. Access to their pharmacist, access to their healthcare provider, pharmacist, and we realized they were going to need access to testing. And so that was one of the very first issues we attacked early in March. Was able to work with the California Medical Association, along with the Primary Care Physicians Association, to say, look, you know, to the government And, you know, we've got a network out here that can do the testing. And we want you to use the existing network, which includes your 47,000 licensed pharmacists and all of your pharmacy professionals as well. And so it was really a great opportunity to build that sense of collaboration with our other healthcare partners and to work with them to advance the access for patients to testing. Now, it was a long and agonizing ordeal, really, to get that waiver through. And I will just say, in a lot of ways, it was a lot easier being inside the Capitol building, being lobbied, than it is sometimes being on the outside and doing the lobbying. But how important that is. We call it advocacy. And I think we all understand in life that we're not going to get things if we don't push for them, if we don't ask for them, and if we don't make the case for them. And so that was really, I think, the task before us on this issue of testing, and it's still the task. I mean, we're not even near where we need to be with this issue. So I would say that for my role in particular, it was about reaching out to the pro tem of the Senate, reaching out directly to the governor, reaching out to the governor's staff, the staff within the Department of Public Health and Department of Consumer Affairs, and the Board of Pharmacy. And I think as we continue to pressure them on the fact that the Pharmacist network is an incredible resource for the state in a time of crisis, let us help you activate and mobilize this resource to meet the need of patients and to use this profession to a fuller extent. Finally, we were heard, and I'll share one story. We were in a hearing where the legislature came back and was like, "Hey, Governor, what have you been up to? We've been gone for 6 weeks, and you've been doing all kinds of stuff without our involvement." So they were checking in on the governor and on the COVID situation, and they were very upset. Up in Northern California, one of the senators was like, "My constituents have to drive 2 to 4 hours if they want to test. And this is just not even doable for my constituency." And so we were very happy to whip out our map that shows where all the pharmacists in California are located, 47,000 of them, and point out to that senator. And then we pointed out to literally every member of the legislature, all 120 of them. Hey, you've got 700 pharmacists in your district. So you know what? Your constituents don't really need to drive 4 hours to get that test. If we can work together, get this waiver that we did finally get from the governor and DCA, and then we can really fill these gaps. We can meet the numbers, we can meet the need. So that's, I would say, one of the primary focuses that we had, but we did a number of other things besides that early collaborative work and advocacy work. We worked on communication. We set up a task force. We set up a town hall system every 2 weeks where we're communicating with pharmacists. We have a website with resources on it, really up to the minute information that our pharmacy professionals needed as things were changing day by day in such a intense environment. And then I think that one of the other big issues was the issue of PPE. Frontline providers. How in the world are we putting our pharmacists out there without the protection that they need? And so we worked very diligently and on this issue of making our government aware that our pharmacists are frontline healthcare providers. And I am really thankful that what we have been able to do, even in this last week, what we have been distributing is PPE that the California state government has provided, surgical masks and gallons of hand sanitizer to members of CPhA across the state. It's 500,000 surgical masks. We were in San Francisco, San Diego. We're going to be in Sacramento Friday, doing this distribution in partnership with the government. And so you find sometimes that we're pushing hard and at odds with them and saying, "Come on, get on our page." But then you've also got to be ready to say, "Hey, now we're partnering with you and we can be stronger together." And so I think that's really been our approach, to be that voice, to hold government and bureaucracy accountable and then to say, hey, we can really help you solve this problem and find a better way. Pharmacists are there. They're stepping up on the front lines. They're shoulder to shoulder, really, with everyone in the state, being leaders in solving this crisis.
Absolutely. And you touched on a word that is often used here within, I imagine, all universities, and that's, communication. And many students here on campus and other campuses are asking, their professors, what is the evolution of pharmacy? How can we influence the evolution of pharmacy? Who do we need to communicate with? Who do we need to partner with, and so forth? So as part of that, a question that comes from students is, what are we doing to assure pharmacy has a voice at the table, at the table where legislative types of platforms are created? And how can students and pharmacists become more involved in directing that future?
That is a great question. And when I was serving in the legislature, I toured Toro University. It was in my district. And that tour was very critical and important. That face-to-face meeting of the legislator with their constituent, and that's a voting constituent, has tremendous value. And so I would say the number one most important is the direct contact between the pharmacist and their elected representative. And I'm sure we've all heard all the voting campaigns, get out and vote, get out and vote. And I would just say, get out and vote and then go meet your legislator. If you really want to have power, that's where the power lies. It's in the relationship. It's in making your legislator collaborator with you on behalf of the profession. And then, yes, certainly we work in the Capitol. We need our pharmacists to come and be that voice, and we do that work as well through legislative days. But there is nothing like the local connection within the community. You want your legislator, your assembly person, and your senator to know that you're shopping at the same grocery stores they're shopping at. And I'm sure Assemblymember Cooper is experiencing this all the time, and that they're going to see you in the community, and that you're there to be someone that's going to network for them as well, right? This is another form of collaboration. You don't want to just always be the one asking, because there's millions of Californians asking for things from their legislators. You want to form the relationship that says, yeah, I need you to understand this profession and where we can help you solve your problems. If you have patients who aren't being able to get in, if you know that we need to keep healthcare costs down, we're the answer to that. We're part of your solution. Then the legislator is like, yeah, I want to meet with you. You're not just about the problems, you're about the answers. And that is a very powerful dynamic.
And I agree. I think we all want to hear someone approach us with a solution, not just the problem.
Yeah.
I think the students are definitely geared that way. They're really interested on what can we do, and hopefully we'll continue to let them know what they can do.
Yeah, invite that legislator to your school, have them speak in front of that student body. They'll come, and it will be a dynamic interaction.
Yes. Well, thank you very much for your insight. Thank you very much.
Thank you.
My next question is for Dr. DeMartini. And I know that Dr. DeMartini and your organization has done a huge amount of work within supply chain in providing the types of things that are necessary for hospitals to be able to do the things they need to do, particularly in this pandemic. So it's obvious to all of us that early in the pandemic, we would hear almost daily about how hospitals were inundated with new cases of COVID-19, shortages of hospital beds, ventilators, and so forth. What has CSHP's role been in the evaluation and coordination of hospital programs, supplies, etc.? And what are we doing, if anything, to assure future reliable supply chains? Well, I think you're on mute.
I guess I was practicing.
You were trying to copy me earlier.
Before I kind of jump into that, I want to echo what Susan just said, because it can't be overemphasized. And Susan being on both sides, having been a legislator and then sitting on the side of an association advocate, she is absolutely spot on. It's all about relationships. And I think the average citizen doesn't feel like they have a voice. And they do. They really do have a voice. Having sat on the government side with the governor and reviewing those bills that came through and looking at who's supporting it, who's not supporting it, one voice can be pretty powerful when you have a relationship with your legislator. And more importantly, have a relationship with him and her before you ask them to do anything. So we always encourage not only our members and pharmacists and pharmacy students, find out who your legislator is and go visit them. And most importantly, most people don't know what pharmacists do. Unfortunately, they think we just know how to count by 5, unfortunately. So we got to change that. So, but to your question, I think there isn't a person in this country that didn't hear at least once the story about not having enough ventilators. But what people didn't hear, and it was terribly concerning, is that the medications that you use to vent a patient, so your neuromuscular blocking agents, your sedatives, your vasopressors, were dangerously low in supplies. Individuals with COVID-19 who are on vents actually go through more meds. We learned from our colleagues in New Jersey and New York, they have a burn rate of 3 times greater than an average vented patient. And we were hearing stories when we were connecting with our leaders in the hospital areas. We were hearing where they were literally, in some cases, hours away from running out of medications. And we were talking about we're talking some major hospitals where they literally said, I've got vents. I don't have the meds. Where do I get the meds? So we were raising the alarms both on the state level and also on the national level. We were interviewed by the FDA Medical Policy Division. They wanted to know exactly what was our supply and demand, and we couldn't tell them that because, first of all, we don't have access to the amount of supplies in each hospital other than to tell them this is a real serious issue. We had some hospitals that were fine. They never got the surge. So they had plenty of medications, and then you had hospitals in neighboring communities, counties, that didn't have the medications. So working with our partners, the California Hospital Association, communicating through our lobbyists, the Vitamin Group, and that's also about relationship building too. They open up doors for us to have a voice. We worked with the Office of Emergency Services, the California Department of Public Health, and what was a little shocking was they thought that these concerns that we raised were theoretical. And that wasn't until we started bringing them the stories to them and saying, there is a shortage of critical care medications. Now, in our country, there are ways for us to acquire supplies, medical supplies during an emergency, and it's our stockpile. And there is a pharmaceutical stockpile. I actually worked the stockpile when the H1N1 epidemic hit, and I can tell you where the warehouse is, but I would be summarily shot probably. You're not supposed to know where the warehouse is. And so we tried to ascertain, was there medications in that warehouse that could serve these hospitals that were hotspots and running out of medications, but we really couldn't get information because it's a bit top secret. But we kept raising the alarms, kept communicating to the governor's office and to the Office of Emergency Services. And we found out, guess what? There aren't medications in that stockpile to address vented patients. What's in the stockpile is to treat blast and burn outcomes. And that's really a 9/11 response. So we continue to raise our concerns about critical care medication shortages. And I'm happy to say that the CDPH has been an engaged collaborative partner. They heard us, and they've actually working through the federal government. They have changed the supplies that's in that stockpile to include, for the first time ever, controlled substances, which are necessary for vented patients, and also medications to manage vented patients. But here's the thing is they're the last resort. So the way it works, and most pharmacists really don't understand the whole emergency response process, which is complicated, but it's there to support our hospitals. If you need supplies, you go to your local, then you go to your regional, mutual aid. If they don't have it, then it goes to the state. If they don't have it, then it goes to the feds. Our hospital pharmacists weren't really aware of this system for pulling the chain to say, hey, we need more fentanyl. Instead, what they do is what pharmacists do very well. They fix things with bubble gum and duct tape, but they fix things. So they're working with this fragmented medication distribution system and digging into the gray market and robbing Peter to pay Paul to get the medication. So we were successful in raising the awareness, successful, at least there's some intermittent steps to address, hopefully won't happen, but the next surge with COVID and or the necessity for medications to treat vented patients. I will say this whole pandemic has raised a lot of awareness as to the deficits in our system, whether it be health disparities, which has clearly been demonstrated, whether it's a fragmented medication distribution system, and whether it's the proper training of individuals to understand how to activate the emergency services. That's a little long-winded for your question.
No, not at all. And I think the audience wants to know. I mean, they really do want to know. And they want to know beyond just the superficial type of answers that sometimes they hear on television. So I think it's very much appreciated that you went in depth and certainly alleviate concerns because I think some people feel that, we're not out of this yet. And will we be better prepared next time than we might have been this last time, right? And maybe we were prepared too as well. So, but I'm glad that through your work and your organization's work that the appropriate types of medications are there now to be able to get us through. So thank you very, very much. And thank you for that explanation. Dr. DeMartini is joined by the CSHP president, Dr. Lisa Gunther-Lum. Dr. Gunther-Lum, if you can add your perspective to some of the organization's challenges or other challenges that have been already mentioned, and how pharmacy is organized to find that key word against solutions.
Thank you. Well, I have to tell you, I practice in a hospital in Los Angeles County. And if you're not aware, Los Angeles County was a hotbed of COVID. And Los Angeles City was the #1 affected city, and my city, Glendale, California, was the #2. So we had a large population of COVID and roulette COVID patients in my institution, much higher than any other hospitals in the area. And we were deeply affected by these drug shortages. We, like many hospitals, not only in California, but all over the country, started a special watch list of medications to make sure we had a good handle on our supply and how many we were getting. We had to do everything in the books to get some of these medications. We borrowed from some of our sister hospitals. We tried to borrow from some of our other local hospitals, but everyone was in the same boat and wouldn't share anything. We started, running up the supply chain. We had to buy from gray market sources. The drug wholesalers were putting on allocations because they didn't want one institution to buy up a bunch of medication, that they needed to be available for everybody. And the way they started doing that was you had to share with them the number of COVID patients and roulette COVID patients you had in your hospital before they would release any medication to you. So there was a whole lot of obstacles put in our way besides just running out of these medications. The medications that were the most troublesome for us to get were the fentanyl, hydromorphone, Propofol, and the cisatracurium, which is a neuromuscular blocker so that your patients are relaxed and can be ventilated and don't fight the vent. At one point, we were probably half a day away from running out of cisatracurium, and we were in a panic, let me tell you, because if you can't sedate or sedate the patients, and they're going to fight the vent. It's worthless having vents. And we never had a problem with the ventilators. We had a deep problem with the medications. The other medication that we were probably less than 12 hours away from running out of at one point was Propofol. And that's another medication that's highly used for every ventilation patient. And like Dr. DeMartini said, it's not just your normal supplies that you need to have extra on hand because these patients are going through 3 to 5 times the supply that a normally vented patient in an ICU setting would go through. So we were deeply affected by this, and I can't say enough for Dr. DeMartini helping to raise awareness and raise a flag that there's a problem here. There's a real problem here, and these hospitals, everybody knew. It wasn't just me, but it was all over the state where we had immense issues with supply, and we made sure that CPhA heard us. And you know, she's right. We had no idea that, you know, what to do in a time of crisis. How do you make people aware? We were discussing it amongst all of ourselves, but we didn't realize how do you make the powers that be aware of these issues, and how do you solve them without just begging and borrowing and stealing from one another. So that was a huge learning curve for us, and one that I think is going to go on for some time to come, because we need to have these discussions regularly is what we found out, so that we're all aware and we have a mechanism to share.
And just to add on to that, one of the things that we clearly emphasize with the administration and with our partners with the California Hospital Association is we may get through COVID and the vent patients, but when we start opening hospitals for elective surgeries, they use the same meds. So you have a double whammy. You have the acute phase, and then you have the chronic phase of critical care medication shortages, which again just highlights the fragmentation and the dysfunction of our medication distribution system.
Is there, I mean, I think the phrase I really picked up on was everybody or no one really wanted to share, right? And you know, I guess you can look at, you know, they're anticipating their own needs, that they have their own facility to take care of. But is there any thought to like a universal gatekeeper, like some sort of all-encompassing gatekeeper system that says, okay, you have X amount, you have X amount, you have X amount. Let's see what's going on. You know, like on the news, we heard that potentially there was a warehouse that had a lot of ventilators in it. You know, what was there, or is there a universal or gatekeeper system that keeps tabs of where everything is?
That's an interesting question. I would say so far not for these medications other than the national stockpile that Dr. DeMartini was talking about. However, one area that does have something like that is the distribution of remdesivir, that investigational Gilead drug that is supposed to decrease the length of hospitalization in COVID patients. So the CDPH has done a very, awesome job, very nice job in kind of corralling that and spearheading that, doing the distribution based on the number of COVID patients you have. And if you had product remdesivir on hand that you didn't need because for some reason your COVID patient population went down, or the converse, your patient population went up and you needed some and you weren't given either enough or a part of the original distribution, the CDPH for each region and each county kind of spearheaded that remdesivir distribution and tried to, like you said, share among the different institutions.
So we actually sent a letter. I sent a letter to the governor petitioning him on 2 issues. One was the necessity of having a statewide mechanism for the distribution of these critical care medications. I'm not suggesting hijack medication distribution system, but all individuals should have right to access to life-saving medications regardless of their location. So we had hospitals that were in the desert who had plenty of medications, and then we had hospitals such as Lisa was talking about who didn't have these medications. And how is it that we create a level of transparency on the distribution of these medications? Now, that's a little difficult to do. However, it was done very well with remdesivir, which it was distributed by allotments, and in some cases, CDPH staff were driving it to the hospital. In that petition that we sent to the governor, we also share the concern regarding the lack of transparency on the acquisition and distribution of personal protective equipment, and particularly for pharmacists. Pharmacists that work in a licensed healthcare facility, their employer under Cal OSHA are required to provide them with PPE. That's assuming there's adequate supplies. But that's not true for pharmacies and pharmacists and pharmacy technicians. They fall outside of the labor code. They're not even mentioned as healthcare providers in the labor code. And we heard the stories of people having to purchase their own masks working in pharmacy. And if there's one thing that we've learned as society, is that these pharmacists that are there are the front door to healthcare, and they didn't get to go home. They stayed there and they did their jobs, exposing. The only thing that protected them from the coronavirus was 36 inches of counter space. So we also share the concerns that was raised by Susan as well about the PPE. And there is actually a bill that was just introduced by Senator Pan that is attempting to address this issue.
Oh, good. That's excellent. And I know a lot of work has been done behind the scenes that many people don't know about. And I'm glad that we have the opportunity through this forum to let students and let the community understand that our state pharmacy organizations are doing a lot behind the scenes, and many times they just don't realize that. Thank you very much. My next question is for Dr. Dang, and Dr. Dang, you're pretty much, I would call you the guru of COVID-19. I mean, you've done a lot of work. I've watched many of your webinars. So, Dr. Dang, the CPhA COVID task force has been a steady source of information during the pandemic. Can you discuss some of the things that you have done as a leader of the task force, and what might we expect in the future from you?
Yeah, absolutely. Thanks for having me tonight. First and foremost, I do want to recognize the other members of our task force, as it's been really a big team effort between our task force committee as well as the association staff. Ever since early March when we were assembled, it's just been weekly meetings, putting out fires here and there. And I'm sure as we were all learning about COVID, just figuring out how do we live with this situation, just learning about how to handle infection protection and how to handle workplace controls and all of that. There were just so many things. And after we thought we resolved one issue, another issue came up. If it wasn't PPE, then it was testing. If it wasn't testing, then it was billing. If it wasn't billing, then it was shortage of medications. So there were just lots of things happening. And as you mentioned, on the back end, the association is doing so much work to make sure that our pharmacy professionals are able to work efficiently, effectively, and safely. So I do definitely want to recognize our task force members, including myself, who's currently serving as the chair. We also have Dr. Jeff Gold from Chapman University, who's an expert in public health, infectious diseases, and immunizations. Dr. David Hoff from Stanford Medicine, who's working in the inpatient hospital critical care area. He's also an infectious disease specialist. Dr. Lynn Lee, who is the Vice President of Pharmacy for Rouse, the Kroger Company, major community pharmacy chain. Dr. Naomi Floria, who is the Chief Pharmacy Officer for private concierge medical practice. And Virginia Harold, the former executive of the Board of Pharmacy. So with the expertise of our membership, we were able to tackle the COVID-19 issue from a variety of different aspects. And we were really able to tap into their expertise to work on a number of different issues. First and foremost, as COVID-19 began to emerge, one of our biggest concerns, as Laurie and Susan talked about, was protection about our pharmacy professionals. We were hearing these horror stories about pharmacists, technicians, students not being provided with their adequate PPEs. The association raised the bell, raised the alarm. We put out several press releases, as well as board position statements, asking employers, government agencies to recognize pharmacists as frontline healthcare workers who needed to have access to personal protective equipment. In addition, we advocated for the right of the pharmacy professionals to be able to supply their own PPE without consequence or repercussion if it was unable to be provided by the employer. And so we were really advocating for that. And As a part of that, the task force released several versions of our infection control document. We really got ahead of the issue, and we even published recommendations about workplace safety before the CDC, before CDPH, and before the FDA had a chance to do so. So we were on the front lines here, advocating for our pharmacy professionals to have access to the necessary protections within the pharmacy workforce. Shortly after we released our documentation and recommendations, we saw the CDC come out with their set of recommendations, which really mirrored the recommendations that our task force came with. So we're really proud of the fact that we were able to influence some of the conversations about how to effectively protect pharmacists, technicians, and students in the workplace. That PPP issue really culminated with major success that Susan referred to earlier, where we were able to work with the California State Office of Emergency Services to distribute PPE, masks, and hand sanitizers to pharmacies across the state. And these were free supplies of at least 2 weeks worth of PPE for our member pharmacies. So that was a major issue that we were able to tackle. Another issue that we recognized was just the lack of awareness amongst all of our stakeholders, amongst our patients, amongst consumers, amongst fellow advocacy groups, and amongst our own colleagues. And as a part of that, we recognized the need to put together a multitude of resources, and we made that readily available on our CPhA webpage at cpha.com/COVID-19. And I would like to screen share that with you for just a moment. So on our main page here, the COVID-19 resource and updates webpage, we have a lot of resources. This main page is dedicated to more of the consumer-facing side, where here we've created several public service announcements about hand hygiene, proper glove use, proper mask use that can be shared with members of the public. We've also generated several infographic handouts that have been widely distributed across social media to consumers as well. Specifically for pharmacists, we've also generated several continuing education programs so that our colleagues are better equipped to handle the COVID-19 crisis. So we put together CEs on CLIA certificate of waivers, the basic of COVID-19 pharmacotherapy, understanding the validity of COVID test results, understanding the FDA regulatory process for emergency use authorization, and understanding the clinical utility of various diagnostic and serologic COVID-19 tests. On our specific, on the subsequent page here for the guidance updates with our task force materials for pharmacy professionals, you can see all of the different resources that we compiled from scratch for all of our members, including the board position statements that I referred to and the different versions of our recommendation documents for infection control and precautions for pharmacy personnel in both community and hospital practice. We update it regularly as more information comes about. We've also created several algorithms for employers to decide on return to work criteria, how to handle exposure within the workplace, how to handle disinfecting your facilities. We created summary documents and decision algorithms about COVID-19 tests, summary tables of all of the different CLIA waived and FDA authorized diagnostics that are out there. We've also compiled billing codes that are relevant to COVID-19 for our pharmacy professionals who are interested in reimbursement and payment. And our most recent document is our recommendations on immunization services, recognizing the important role that pharmacists play in providing vaccinations. We've seen a major drop in the vaccination rates across the United States. And the most recent figure within California was that there was a 40% decrease in the routine vaccines that were received, especially amongst the pediatric population. And we recognize that pharmacists play an important role in that. So we created several recommendations on how pharmacists can provide these services in a safe environment, which involves the use of PPE and other safeguards. In addition to creating our own documents, we've curated several documents, resources, and websites, including clinical practice guidelines from the NIH and IDSA, information from various health plans about payment and reimbursement, resources from the California Department of Public Health, CDC, FDA. So we curated all of that for our members and it's available on our website. We know that there's a lot of information out there and it's really hard to figure out what is reliable and what is good information. And so we took it upon ourselves within the task force to really provide those resources to our members. So you can see that we created things for the public, for the consumers. We created things for our fellow colleagues, pharmacy professionals. And as Susan mentioned, we also advocated very hard on many of these issues, just on not only on PPE, but even speaking about the testing issue. You may, as some of our attendees may recall, there was a constant struggle back and forth between the state and the federal government about can pharmacists test or can they not test? And it was an arduous process of educating legislators about what the issue was. And the association played a major role in educating the California legislators about the role that pharmacists can play. And that ultimately culminated in an executive order from Governor Newsom recognizing that pharmacists have the authority to order and administer COVID-19 tests. So that was a major accomplishment and major achievement and recognition of the role that pharmacists can play. And in order to achieve that, we advocated not only with the legislators, but we also raised the issue amongst the media and the press. We conducted multiple interviews with various newspapers and news agencies, including the San Francisco Journal, NPR, Drug Topics, just to raise awareness about the fact that pharmacists weren't being recognized as providers for the purposes of COVID-19 tests. And now that we have that executive order, we also see that the federal government at the HHS has declared similar authority for pharmacists, which provides a major opportunity for pharmacists to serve the communities that they live in. So that's just a kind of a summary of all the different things that we were able to accomplish. And it's been a lot of work in a very short amount of time, but it was possible because of the members of the task force and the staff who've dedicated day and night. And as Susan mentioned, information was changing on an hourly basis. And we had to really keep on top of that so that we could provide our members with accurate and up-to-date information that they could use in the workplace.
Well, thank you. And I think again, this really shows, and all the participants within this presentation today is really getting a behind-the-scenes insight as to what their pharmacy organizations do. We recently ran a survey to ask, how many pharmacists really know what their state organizations are doing? And it's quite surprising. I think prior to COVID-19, that number would have been relatively low. As a response to COVID-19, I think the communication has increased dramatically. And I think the response of all pharmacy organizations has been immense. I mean, it hasn't been lagging. It's been, let's be proactive. Let's get out there. Let's understand that we need to communicate. And I hear that you're saying that very much so, and all the organizations saying, we need to communicate and we need to let the powers to be know that pharmacists are there and able to do that job. One thing that you mentioned was, you said it was an executive order. Does that mean it's something that's temporary? Does that mean it's something that can be retracted? And that really is for anybody who wants to answer that question.
I think we probably could all answer it together. The answer is it's temporary.
It's temporary.
And yeah, and it's a 1-2 punch, because CPhA was there assertively doing also what we were doing as well, petitioning the governor to allow pharmacists to order and test. I mean, the federal government came out very loud and clear in April. Pharmacists can do this, get out of the way. And it was a little bit of a shaming because other states were doing it, and yet individuals within the Department of Public Health, Laboratory Field Services really felt that pharmacists couldn't. So it was a good example of how that advocacy from multiple approaches came to the governor acknowledging under the executive order he could issue a DCA waiver. So now here's the heavy lifting though. Are we doing it? Are we doing the testing? Are we doing the ordering and testing? And the next thing is treat. We need to line this up for treating. And I'm sure CPhA is working on this. We're working on it. We're raising it at the national level to get pharmacists to be able to immunize and not wait for it to be on the ACIP guidelines required under BNP code 4052.8. But the key here is, if we've been given this authority to do these things that we've been prohibited from doing before, we better make sure that we actually do it and then show we can't contract. We should not contract back to the way it was before COVID. COVID has given us an opportunity to advance, as you say, the evolution of our profession by really showing to the public what we are all about. And that's my hope and prayer, is that we will have those stories to tell and to say, let's not contract back. An example is telehealth. CMS administrators already said, we're not going to go back to the way things are. And where are pharmacists at in telehealth? Providing care to their patients remotely. And that's an access issue, big one.
How about, and this is for all the panelists, is one day a vaccine will certainly be made available, I'm sure. You know, what is it that will need to be done to assure that pharmacists are one of the providers for that vaccine?
Well, we're really going to need either state legislation or an action by the governor. And I think at this point, it's really going to be legislation that we're going to need here in California. We've already seen Governor Cuomo in New York take action and sign legislation, I think yesterday or the day before, in New York, allowing when the vaccine comes that pharmacists should be able to give it. It makes perfect sense. And so I'd say, you know, as we look at the next few months, that's going to be a very big focus for us, is making sure that we don't wait to get caught like we did this time, unprepared, not quick to act, and that we know that we are going to need that authority here in California for all of our pharmacists. So that's something we're actively working on. And I think it's, you know, the healthcare profession understands that the pharmacists are very important in playing this role around vaccinations. It is a key function for the pharmacists. But, you know, the other hand, we're very well aware that there are issues of billing and reimbursement. There are issues of staffing. You know, load more work on the pharmacist. That's great. We need to actually make sure that we are also addressing the system issues within the world of pharmacy and the billing issues, so that everything is working together to actually get the vaccinations to our patients.
So just to kind of build on that a little bit, is that currently in the state of California, pharmacists can immunize under two sections of our B&P code. One is through a collaborative practice agreement. So if you work for a public health department, you could do it under the medical officer. The other one is independently, but there's certain criteria that have to be met. And one of the rate limiting ones is that the vaccine has to be on the ACIP guidelines. So that takes months. However, and so we're raising that on the national level to have conversations with the individuals on the national level of move faster when this vaccine comes, so that it does get on the ACIP guidelines, but also at the same time looking for opportunities and avenues. And one of them can be legislation. It could be adding an addition to legislation that's specific just to COVID-19 and not wait for Health and Human Services on the federal side to put it on the ACIP guidelines. But here's my prediction. Given the fact that they came out loud and clear about activating pharmacists to be able to order and test for COVID, I don't think they're going to drag their feet with putting it on the ACIP guidelines. It's that agency that reports to Health and Human Services. I have faith anyway, but in the meantime, you got to have plan B.
Yeah, certainly.
That is true.
Yeah, those
Every
who,
single
what is it?
angle.
What is the saying? Those who fail to plan to fail, right? So thank you. And again, thank you, Dr. Dane, for that was very impressive. And again, it was a good way of showing just what it is that our pharmacy organizations are all doing out there. The next person I want to move on to now is Mr. Hothe. Mr. Hothe, I'm sure the legislature has been inundated with COVID-19. How has COVID-19 changed Assembly Member Jim Cooper's priorities this year and any budgetary considerations that he might have in front of him?
Yeah, so we started off the year with 18 bills in our legislative package, and we're down to, sadly, just a handful, and they're all pretty much COVID related or public safety related. On the budget front, Assemblymember Cooper chairs Budget Sub 4, and instead of talking about increased funding for various groups, now we're talking about how much we need to cut. So that's just the sad reality that we're living in right now. Our office has had to close down. I've been working remotely for the last 3 months. All of our public events were canceled, all of our district activities. And so we've had to become creative in figuring out ways to engage with our constituents. Also, I heard former Assembly Member Bonilla was talking about having relationships with your elected officials and lobbying. And I'm sure there are a lot of students who are listening in on this call. I think Northstate University, which is in our district of Elk Grove, is really effective at doing this and in including their pharmacy students, their nursing students, and having them do volunteer hours with our office and helping to develop the rapport. They'll have students come out and do blood pressure checks and administer vaccines, working with county public health and instructors, and it just helps to have that relationship, that rapport, so that when time comes where you're talking about potentially having pharmacists administer COVID vaccines, well, we know that the nursing students at Northstate University have the capacity to do this sort of work, and I'm sure that they've been in the game for much longer, have that capacity as well. So I think as Ms. Bonilla was saying, it does come down to those relationships. So other than that, on the community front, we've had tons of constituents that have had unemployment issues with EDD. Assemblymember Cooper has been doing, he had a budget subcommittee hearing where kind of had to rake EDD over the coals for a lack of responsiveness and dealing with the issues that folks are facing right now. And you have some people that are waiting 3+ months for their unemployment claims to process, and so that's been a priority for Assemblymember Cooper and ensuring that his constituents are getting the resources that they need. So just a few of the things that we're dealing with in our office.
It's interesting. I know you've been in your current position since 2014. I'm very much interested in knowing, and I guess this would be more of a personal question, what your view of pharmacy and what a pharmacist did and was prior to your being involved in the legislature. And would you say that your colleagues overall have a good understanding of what pharmacists are capable of doing? Or do you think we're still in kind of that learning process? We really need to be more active about educating the legislature about what it is we're doing.
Yeah, so I have some family members that are pharmacists, and so I'm a bit, I'm kind of aware of the profession. But since working in the legislature, I actually used to work for Dr. Pan when he was in the assembly, and Dr. Pan's all into doing legislative tours, and so we toured a number of pharmacies and got to learn firsthand some of the issues that you folks face, and so that's been helpful. I can't speak to assembly members from across the state, but I can tell you that Assemblymember Cooper likes to go on these tours as well and fairly informed of some of the issues. But of course, it takes proactivity from the local pharmacists to ensure that you're engaging with your legislators and educating our offices on these various issues.
Yeah. That's been very much a resonant theme throughout all the leadership that's on this panel. Each and every one has advocated that we need to develop those relationships. And it really does come to that in the end, doesn't it? It's just developing, being seen, having a conversation with the right individual at the right time is absolutely critical. And I think many people, some understand that it's just that simple at times, right? And I know everyone on this panel does. So my second question for you, Mr. Hothe, is since there are many students listening, can you elaborate on where students and or pharmacists can become active participants within the state capitol? For example, healthcare committees or help on special projects to really get that relationship going?
Well, I know when I worked with Dr. Pan in the assembly, we actually had pharmacy interns in our office. And so they worked on various public health issues. We also used to do like workshops where we'd have pharmacy students come out and educate high school students about, we used to do like tobacco town halls and, some nursing students involved with that as well. So I think there are ways to get creative. My recommendation, at least for the folks in Elk Grove and Sacramento, is to look at your school. Northstate has tons of these opportunities available for, to come out and volunteer. We do a back to school health and wellness fair every year and a turkey giveaway where we have thousands of people show up, and Northstate provides dozens of volunteers that will come out and do these, different blood pressure screenings. And it's just a good opportunity for students to be out in the community. They get to meet their legislator, all the major, community stakeholders that come out to these things. And it's just a good way to become engaged. And then maybe you develop that relationship, that rapport, and later on you're interested in, an internship. Or we have a young assembly members program in our office that we typically do during the summer. Obviously it's not going to happen this year because of COVID, but it's just a good opportunity. We have high school students come out for 4 to 6 weeks and try to educate them on different public policy issues. And it'd be interesting to try to get some folks from, from the pharmacy profession and talk about, some of the things that you're all dealing with. So I think there are opportunities to get creative here. But first, I'd recommend looking to your respective schools and figuring out what those opportunities are.
Absolutely. It's definitely been a large discussion here at the university, and we're going to take that as a personal invitation to become involved. Okay? So thank you very, very much, and I appreciate that insight. So now we're going to move to some questions that are coming in. It's that part of the hour. And I am just so impressed with the leadership team that we have here today. And I think the pharmacy is in very, very good hands. So our question is, we have a question that came in that says, and this is coming in from a student. Wow, they've been really flowing in here. Pick one that maybe hasn't been addressed. So I have a question here. Here's a question for Miss Bonilla, from Alexander. In regards to the COVID-19 testing, are there numbers out for how successful having community pharmacist testing has been? How has that impacted their work? And how do you all cope with PPE required for these pharmacy staff?
Mm-hmm. There are no comprehensive numbers out yet. I think we're just getting started, but you are seeing it popping up around the state. We have some of our corporate pharmacies, our chain pharmacies doing testing. We have some of our individual independent pharmacies just beginning to do testing as well. Right now, I think we're looking at, how does the process work? So that question of PPE is one of those very important questions. And are we going to do it as a drive-through, or is somebody going to come in to the pharmacy itself? What does that mean with social distancing and other people in that pharmacy setting? So the process is where attention is right now. We're working on a pilot project in Contra Costa County with the County Department of Public Health to work with the independent pharmacists to say, how are we, you're already in a contractual relationship, many of the pharmacies, but how are we going to make this work? What are the steps for the pharmacist to be able to actually sign up? Things like, what is the screening form going to actually read? What does the county need? What questions need to be answered by the person who is coming in for the test? And then how are we going to handle the results as they come back? So there are many layers of detail that I think all of us are really focused on right now and working on. But I really do see this as a long range. The testing is a long range process that we're going to be involved in for quite a while here in the nation and in California. It's not an overnight, oh, well, we're all done with testing for COVID, because even with a vaccination coming, that testing process, we're hoping will become much more readily available and really help us determine the treatments that are necessary as well. But that was a great question. And I think it's something that right now your county departments of public health are actively going to be working on how to answer those questions to make this actually effective throughout the state.
And then if I can add as well, so some of the other things that we're working on is, like Susan said, is peeling the layers to make sure that we can operationalize and implement everything. I want to highlight that, even though we've received the authority through the executive order, it's not a light switch that you can flip on and off. Now with the authority, we have to interact with several agencies and health plans that aren't used to interacting with pharmacists, right? So in terms of payment, it's quite clear through federal legislation that any provider who orders a test should get paid for those services. However, many health plans are not used to involving pharmacists in their medical benefits, involving them in payment. And so now we're really knocking on those doors and saying, let us in. And we see that's a really good opportunity to get our foot into the door on COVID testing issues. And then hopefully that can snowball into other clinical services that pharmacists and pharmacies can offer. So we're really looking towards that Contra Costa pilot to demonstrate some of the ways that we can work with a health plan. We can figure out some of the supply chain issues, not just with PPE, but with testing swabs and delivery kits. And then once we have success in that region, to really scale up to the rest of our member pharmacies.
And actually, Dr. Dane, you literally just asked one of the questions that came in from a student that, their observation was we have a tendency to offer services, almost from the goodness of our hearts, and that's admirable. It's very altruistic. But there's a fact in reality that when you provide a service, payment is a natural expectation as well. So good, excellent. I'm glad to hear that we're doing that and pursuing that aggressively.
Absolutely. The payment issue is definitely one of our next big topics that we're tackling with the task force. And we're definitely not in the habit of providing things for free anymore. We need to be properly compensated and paid just like the rest of our healthcare colleagues.
Yeah, absolutely.
And I think that's
absolutely.
one of the ways that we can use a crisis and begin to really turn it into the education, the effort, these resources, really begin to pivot from a crisis in the next year or so into the role of the pharmacist. And I think there's great opportunities through all the relationships and work we're doing. It's not just going to end with COVID. We're really hoping this is laying the foundation for establishing the pharmacist as a healthcare provider in many, many ways and within the system itself. So we believe that this isn't just a short burst of energy and short-term effort, but it's actually going to turn into something of great value for the profession.
And to build on that, couldn't agree more. One of the things we don't always do very well as pharmacists, we take care of business, we take care of the people that we serve, but we don't always amplify our successes. We don't say, look at what we did. We managed to vaccinate X number of people. And it's really important for us to have our voices heard. So I encourage all of you that are in the space and are doing testing, think about how you're going to grab the data so then it can be communicated in an advocacy way so that when you are working on, let's say, legislation or the Department of Healthcare Services as to why they need to pay pharmacists, because we don't give it away for free, you have the numbers, you have the stories, because those really sell. That then gets your legislators and individuals in the executive suites to better understand who we are. We do not do a good job of letting the public know what we do. And this is an opportunity. I couldn't agree more with Susan. Within this chaos, there is opportunities. And it's our opportunity to step into this space. And if we don't, shame on us. If we don't step into the space, own it, and communicate it, we've missed an opportunity that we don't want it to happen again. We don't want another pandemic. But this is our opportunity to demonstrate what we are capable of.
It's really true. One of my concerns in January and February was, how are we going to get the attention of decision makers back on healthcare? Right now, it was all in January, February, it was homelessness. First was the environment, then it was homelessness. But people really had forgotten a lot about healthcare. It was not a topic of conversation. Now, wow, all the focus, all the attention around access and healthcare issues, this is the time for pharmacy to rise up. No question about it.
Is there, I know what comes up in the classroom a lot amongst students is, and the professors ask this question of the students, is how do pharmacists convey value? And what is value but in the eyes of the beholder? So as you mentioned, Dr. Dane, you're working with third-party, maybe PBMs or third-party agencies. The question becomes, what is value to them? I think, I'm sure we're asking that question, but what would you like to see as value from a pharmacist? And what is success when we do see it, right? And I think we all know that pharmacists can provide an unusually high amount of value, but it becomes lost somewhere. Like, what is the value of a pharmacist? We heard, hey, we know nurses can provide this vaccination. How do we show that the individual best suited, or the profession best suited, not just for immunization, but for anything, is the pharmacist?
Mm-hmm. You kind of said it in your question, and it is about value. It's about cost. And if we remember back to when there was the campaign early on, all the candidates for president, and how are we going to have universal health care, and it just costs too much money. A large part of the answer lies within the role of the pharmacist, and that's what the payers care about. We just haven't, educated the payers convincingly enough that the fact that the pharmacist is the one that is going to make the Affordable Care Act actually affordable. But the real key to the affordability is with the patient and the care of the patient. And that's really the comprehensive medication management that pharmacists can provide to their patients. And I think that value in the health of our neighbors and friends and family is immeasurable. And it's one of the main and critical functions as you're managing our chronically ill and their medications and keeping them healthy and out of the hospital. That's what's going to make our dreams achievable of actually having more affordable health care in our country and in California. But that's a message that it's incumbent on us to get out, and we've got to keep at it, and we've got to actually, to quote Laurie, we've got to amplify that tremendously so that people understand the value of pharmacy.
And Peter, as kind of you mentioned the question, value is kind of in the eye of the beholder. So you have to know your audience, who you're speaking to, and what they're looking for. As an example specific with COVID, we know that the state and county health departments have ambitious testing goals of how many tests they need to do on a daily basis, how many tests they want to do within a certain quarter. Specifically within Los Angeles County, we were seeing news reports that the county was having excess testing devices that were going unused. They're getting wasted because they couldn't reach the consumers. And so hearing that, we had one of our task force members who worked for one of the chains reach out, develop a relationship, and as of this past week, has begun hosting testing sites with Los Angeles County as a partner, doing hundreds of tests. And so for that particular region, the value is increasing your testing capacity to reach your goals that you have established. And then specifically with vaccinations, pharmacists demonstrated great value during the last H1N1 pandemic. And that, I would say, really opened the doors to pharmacist delivered vaccination services. And now we have another opportunity to demonstrate that again. So as we meet with stakeholders and legislators, I think one of the key points to demonstrate is that when pharmacists are involved in emergency response vaccination services, we can vaccinate a majority of our communities 7 weeks faster if we activate our local community pharmacists. 7 weeks faster, and that's major when we're talking about a novel disease. And so as we're going to be having these conversations to make sure that California pharmacists can administer the vaccine as soon as it's available, that will be one of the key pieces that we already have data that we can bring to the plans, that we can bring to legislators, that we can bring to the key decision makers.
I want to go to your question. You talked about the value of pharmacy. You talked about the value of pharmacy, and it is in the eye of the beholder. And one that gets left out frequently in our discussions about healthcare is the patient. And I'm talking relationships with their pharmacists. they know their medications, they live within their communities. And so in the eye of the beholder, that patient pharmacist relationship is also key, but it doesn't always get risen to the level of having importance in policy development and in reimbursement mechanisms. We focus so much, understandably so, on the funders and how do we raise the voice of the public who is served by these close relationships that they have with their pharmacists, whether it be the community pharmacist or the pharmacist in AmCare who is managing their complex medication regimen and now doing it telephonically. And what we're hearing is access is increased. We have one group that said their failure rate of coming to the clinic was 18%. They dropped it down to 3% when they went to telehealth and with pharmacists managing the medications. So I would say in the eye of the beholder, we need to raise the voice of the patient.
It's interesting on that comment. I've heard a lot from physicians talking about the warm handoff to a dedicated pharmacist, to where the physician does the diagnosis. And this physician was talking to me about, it was actually 3 physicians mentioning about the high burnout rate of primary providers, and how one of them had a dedicated pharmacist who she would send a patient once diagnosed to a pharmacist, and that pharmacist would then take the diagnosis, determine what the appropriate drug regimen was, did everything that was necessary. Did I lose anyone? Oh, very good. My screen changed, I'm sorry. So of saying that this pharmacist was there and took care of all of it, the regular follow-ups, and in the end, the patient was better cared for and had less recidivism than a patient that did not go through that same process, right, with the pharmacist. So hopefully,
the literature is sound,
yes,
especially around hypertension, that pharmacists do a better job managing hypertensive patients and getting their patients to goal faster. The literature is a little still in the gray area on diabetes. It's more anecdotal, but yet the pharmacists are trained to be medication management experts. And with an aging of our population, we're needed more now than ever. And you have pilot projects that are being launched by the Department of Healthcare Services to start providing nursing home services in the home so as to reduce the congested living environments they have for the spread of COVID-19. Well, that's also a place for a pharmacist to move into, is into the home setting as well.
and here's what I'm hearing now, and I know the students that are listening are very interested in, one of their concerns is, you know, I'll graduate, what are the chances that or you know, how soon will it be before I can get a job market, and so on and so forth. And I think what the leadership has said here very loud and clear is there is huge opportunity out there, huge opportunity. And we just all need to become involved. If we want there to be jobs in the future, we need to get involved. We need to develop those relationships. We need to become actively involved within all our organizations, so that we do speak with a potent voice, and then come up with what I'm hearing too. Let's come up with some statistics that show, hey, the pharmacist does have value, right? So there's a lot of different things going on here, and I hear our leadership talking about each and every one of those. So that's fantastic. Here's the next question in from one of the students. It says, this question comes from Betty and is for Dr. Gunther Lum. Are fentanyl, hydromorphone, and propanol medications recommended or used to treat a patient with mild COVID-19 infection?
Thank you. No, those are not for treatment of COVID. Those are medications used for any and all ventilator patients.
Right.
So we use them in our ICU or critical care patients before COVID. We use them in our patients undergoing procedures in the hospital. So if you were getting a colonoscopy or you had appendicitis and you were getting an appendectomy and they do the surgery, those are the medications that are used to tranquilize you and sedate you so that you could be on a respirator for however long you needed to be on. For surgeries, obviously, it's a short period of time. Sometimes in the critical care units, it's a longer period of time. The difference with COVID, though, was the patients with COVID were burning through or using higher doses of medication, 3 to 5 times higher than our usual critical care patients. And so not only did we have all these patients on ventilators that we normally didn't have, we had to reutilize some of our regular medical wards turn them into critical care units to accommodate all of these very sick ventilator-required COVID patients. So not only did we have more beds, but we had the patients using more medication than a normal critical care patient. And so that was the problem with, the supply issues.
And I think we've heard too that a lot of fantastic work has been done about making sure our stockpiles are adequately supplied as well. So that's wonderful. Another question came in. It says, during my rotation, patients were told vaccinations were suspended due to COVID-19 until further notice. I would like to know the reason behind it, if any of you know.
Yeah, so that really came from the CDC. And when this first came out, as we mentioned before, there were a lot of unknowns related to COVID. How is it spread? How infectious is it? What do we need to do to protect ourselves? So when it was brand new, we took a more conservative approach, and the CDC said basically to discontinue or postpone all non-urgent clinical visits, which included vaccination services. But as we learned more about how to better protect ourselves by keeping appropriate physical distancing, using appropriate PPEs, the CDC slowly relaxed their recommendations to allow for the resumption of non-clinical services. And so that's where we are now. We feel comfortable enough to say that we can restart all of those services, including immunizations, as long as certain safeguards are in place.
Excellent. Next question we have, this question is for Dr. Dane from Riley. How has the patient continuum of care from being hospitalized to go home been affected by the stay-at-home orders and social distancing? And how can pharmacies adapt to the new normal?
Well, I think it's something that Laurie mentioned, the increased use of telehealth. We've really seen an expansion of that, not just with pharmacy providers, but with other medical providers as well. And with a lot of the closures of our outpatient facilities, because of that prior CDC recommendation to postpone non-urgent visits, patients were losing access to some of that care. And in order to reach patients to where they were, that would be definitely the provision of telehealth services. I'm sure Lisa or Laurie could probably add on more to that.
Yes.
I think it actually is a concern. There's something that is occurring that hasn't really gotten a lot of attention, is that people are obviously frightened, and they're frightened to go to the hospital or the emergency room. And what I'm hearing happening is that people are coming to the emergency room too late. And this is particularly so with myocardial infarcts, that they're so worried about going to the hospital, they're stepping away from their care. I kind of think in a way that's a way for pharmacists to step in as well, whether it's at the community level, the AmCare level, and have in those relationships that pharmacists have with the people that they serve, to be vigilant about looking for those signs and symptoms of uncontrolled hypertension, possible symptoms of a heart attack. We had a friend of ours, wasn't feeling well for several days, decided to lay down and take a nap, and she died of a heart attack.
Oh my goodness.
And she had the symptoms, but people are scared. So it's also incumbent upon us as one of the most accessible healthcare providers to be aware that we also have this unintended consequence that's occurring with the health of our nation.
Not only are we
Absolutely.
noticing that patients are afraid to come in and they're delaying care, but there's also a concern by many patients that I don't want to use up valuable time. The doctor needs to spend time with those COVID patients and be treating them. My condition can wait. It's minor. Or the use of PPE. I don't want them wasting masks and face shields and gowns and gloves on me when my condition can wait. So they had several concerns, not only trying to delay their care because they thought, maybe they could just tough it out and it may go away on its own, but, using valuable resources was another big concern. They didn't come into the clinics.
Another question just came in. This looks like it would be for Dr. DeMartini. It says, for emergency medication stockpiling, lessons learned from this pandemic, what would you see as the necessary amount to be maintained? Further, how will this impact pharmacy practice going forward? Having large stockpiles also requires proper storage, maintenance, which results in higher healthcare costs. Well, you're on.
Myself again. It's a great question. It's actually a multifaceted question. So our stockpile was really designed for blast and burns. That's post 9/11. It wasn't designed to medically manage ventilated patients. It's also designed as a last resort. So one of the lessons that we learned in talking to hospital leaders, and we have calls every week, and now we're at biweekly, and there's over 100 that attend these calls. We learned quite quickly that pharmacists didn't know, and it's understandable, didn't know about how you activate the emergency services at the local level, then to the regional level, and then to the state. They were trying to take care of the critical care medication shortages on their own or with their sister hospitals or the friends that they had established with other hospitals versus pulling the chain and saying, we need help. And it's not just PPE, we need fentanyl and propofol. So we are extremely rewarded to know that CDPH was listening and they moved, they pivot really quickly. However, they can only store so much medications and they have to rotate the stocks. And now that they're managing controlled substances, there's an added layer. And most people don't know this, but CDPH has oversight of the stockpile. So through the H1N1 epidemic, I actually at the time had oversight of 20 pharmacists, and we were activated to manage the stockpile. So because once you activate the stockpile, a pharmacist has to be there 24/7. So I got the graveyard shift, which was kind of unfortunate. And we were watching TV, and the guy who controlled the remote was the guy who had the 357 gun strapped to his hip. I figured I wasn't going to fight him for the remote control. And that was when we were distributing the antivirals. So this warehouse can only hold so much. It's intended as a last resort. As far as it being a cost to healthcare, it's not the kind of cost to healthcare that you would anticipate. It's one that's also shouldered in part by the federal government and the state government. The cost to healthcare is far greater by not being prepared, and the loss of life and the burning through of the PPE and the impact to our healthcare providers who are contracting this disease and unfortunately suffering devastating outcomes, including deaths. So it's an ounce of prevention for a pound of cure.
Absolutely. And I think one final question that I think is actually quite appropriate is one of the that I'm going to choose as our final question as we round this off is talking. It says from one of the students, what do you think pharmacy will look like in 5 years? How will the profession look different from today?
I think that 5 years from now, we're going to see the expansion of healthcare being provided at the pharmacy level. And I think that that is the interface for so many patients, is that direct contact with their pharmacist. And I think we're going to see a much higher level of collaboration. You've heard the stories as well of the physicians who are becoming more and more dependent upon the pharmacists. They're realizing, oh my goodness, I don't have to keep all that in my brain or look it all up. I've got a pharmacist like right here that I can talk to. And so I really do feel that the pharmacist is going to be much more interrelated in that healthcare provider network. That's part of our job, is to see that happens collectively. I don't just mean, a few people in Sacramento working on it. I mean, every member of the profession agreeing that this is where we want to be in 5 years. And if we have that target and goal, and if we work together, I believe we can achieve it. I believe this is a necessary transition that needs to happen for every single Californian that needs better healthcare and that needs better access. So We can't continue to build, more and more hospitals. We've got to make sure that people become healthier and healthier. And one important element of that is that relationship with the pharmacist. So I think that the outlook is bright for the profession and for the pharmacist, but it really is incumbent on all of us to make that happen. No one else is going to make it happen for the profession. No one else is going to be the champion. We've got to be the champions ourselves.
So I would say there's many factors that are currently going on that are levers for us in this evolution of our profession. One is there's not enough physicians. And there are areas of this state that doesn't have adequate number of physicians, and you can't produce a physician overnight. Whereas you have 1,000 pharmacists graduating every year. So we've hit a situation where we're into potentially a glut of pharmacists. So you've got this resource here, this workforce, who are the experts in medication management. And as you said, physicians are turning their patients over to pharmacists for medication management. That's been occurring for quite some time, actually. And in areas of our state, they manage everything, the hypertension, the diabetes, and they're doing it with their relationships with the patients in a managed risk pool. And so that's where, and then you've got the other factor is, for the first time in recorded history, we're going to have more people over the age of 65 than we do under the age of 18. So, and who consumes the most medications? It's the older population, and it's the complexity of their medication regimens. We're talking about chronic disease management, which pharmacists are well trained to manage. Chronic disease management is what Susan's talking about. Go upstream. Be healthier. It's chronic disease. It's about population health. It's public health fundamentals, and pharmacists are part of that. They can manage the chronic disease. Deprescribing is finally getting some leverage here in terms of start taking people off medications. Don't add more to treat one symptom. And who can do that? Pharmacists are the experts. But I agree with Susan. It won't happen unless you step in. And we can sit here and be a bunch of talking heads and say, this is the way it should be. But unless the students, the future pharmacists and the current pharmacists start stepping up and stepping in and being uncomfortable with doing it, then we're not going to make the change that we need to. And that's going to be part of our, de-evolution. So we've got the opportunities. You got to step in and take it. And these associations, CSHP and CPhA, are here to provide the opportunities to step in. Now you just got to step in.
Absolutely. I think, and this really goes out to our attendees. I mean, it's obvious, I think, to everybody who's watching, as you look at our pharmacy leadership, they're completely in tune with what's going on. They understand what the challenges are, and they're working very, very hard to assure that those challenges are met and those opportunities that are there for pharmacists to be able to take on will be ready for and take those challenges on. And I think that means, hey, they can't do all the work. They need our help. They need the help of pharmacists that are not currently engaged within your organizations. They need the help of students to be active and energetic participants in those organizations as well. And I certainly hope that from this time we've had together, you can really see that. Our time has really come to an end here, and I certainly want to thank everyone for being very transparent and answering questions absolutely as fully as they possibly can. So I want to thank our distinguished panelists for their contributing their time, talent, and knowledge tonight. It's good to know we have such strong leadership at the helm of pharmacy. I also want to once again thank our students, faculty, and community that have participated with us this evening. This was the first of a series of forums that will be hosted by California Northstate with the goal of informing and educating students throughout the state on how to become active participants toward the advancement of our profession. We hope you will join us in future sessions and wish you all a good night. You know, one of the things about, before we sign off, one of the privileges of leadership is the ability to thank those individuals that work behind the scenes. I think our leadership have made it very, very clear that they lead many, many dedicated teams toward that mission for the type of leadership alignment that they are setting. I want to take this opportunity just real quick tonight to thank Mr. Jonathan Ballard. Jonathan, do you have a slide? Excellent. I want to thank Mr. Jonathan Ballard as part of that privilege of leadership. His expertise, his knowledge, his kindness, his giving, his everything in teaching me more about Zoom than I thought was even available. He taught me about Facebook and online presentation skills, really made this presentation possible. Mr. Ballard has an MA from UC Davis. He's a strong advocate for our students across their years of service here at the college, and we are very fortunate to have him as a colleague. So thank you very much, Mr. Ballard. Once again, I want to thank our participants. You've been absolutely phenomenal. I hope we can do this again. You're a wealth of information, and I think you've supplied that wealth to many, many students that were hungry for information tonight. So thank you.
Thank you.
Thank you
Thank
so
you for
much.
having us.
Enjoy the rest of your evening. To all of you, thank you again.
Thanks.
Thanks.
Bye.